takeaway message from our article is that the majority of patients with hepatocellular carcinoma or primary liver cancer live in lower income countries where curative intent therapies such as liver transplantation are inaccessible or unaffordable. My name is Chana Jayasekar. I'm one of the transplant hepatologists at Mayo Clinic, Arizona, and I'm an assistant professor of medicine in the School of Medicine at Mayo Clinic. The title of the paper is Transforming Hepatocellular Carcinoma Treatment in Lower Income Countries, and it will appear in the April 2025 issue of Mayo Clinic Proceedings. There is emerging data that treatments such as immune checkpoint inhibitors, which are infusion-based treatments, which are widely replacing traditional chemotherapy in many types of cancer, could be vital in improving liver cancer care outcomes in these lower income countries. This is in comparison to liver transplantation and other technologically resource intensive treatments for liver cancer, which is the mainstay of treatment of liver cancer in developed or high income countries. But the availability of these highly resource intensive interventions is very limited in lower income countries, as one might imagine. But the availability of oncologic care, where infusion-based therapy can be provided, is much better established. The key barrier to the use of immune checkpoint inhibitors in lower-income countries is their cost, currently, which exceeds about several $100,000 per patient. Our authors, who are hepatologists, oncologists, and program implementation specialists in lower-income countries, argue for strategies that could pave the way for wider accessibility and affordability of immune checkpoint inhibitors for hepatocellular carcinoma, and that until the technology required for these more intensive interventions like liver transplantation are being developed. How this affects patients is that the current standard of care for liver cancer in lower income countries is very rudimentary. The use of chemotherapy agents, particularly sorafenib, which is not particularly effective for this type of cancer and is not curative in its intent. In addition, a large proportion of patients may be simply relegated to palliative measures. With immune checkpoint inhibitors, we may be able to bridge some of these patients to more durable treatment responses and potentially even get them to a point where cancers can be resected and sometimes in a small number of patients cured. And this is the primary way in which we expect this type of treatment to be beneficial to patients. In terms of clinicians, the availability of transplant surgeons and transplant hepatologists and the infrastructure required for liver transplantation is very limited in lower income countries. However, the availability of oncologic care, oncologists and other allied providers in oncology is far more widespread and available. We argue that the concept of task shifting, for instance, could be additionally transformative in the provision of immune checkpoint inhibitors in low-income countries. We draw upon examples in the treatment of HIV and hepatitis C virus in low-income countries where fairly complex treatment regimens were able to be decentralized from highly specialized centers to mid-level providers and other less specialized providers to deliver the same quality of care. And this is a very unique aspect of the ability for immune checkpoint inhibitors to be more widely available and accessible to lower income countries. The next line of research, in my opinion, in this area is finding more efficacious treatments for hepatocellular carcinoma in the immune checkpoint inhibitor realm. The current data is highly promising, although not conclusive as to whether it can be curative in intent. The current studies have focused primarily on controlling more advanced disease. Whether these checkpoint inhibitors can be equally efficacious and potentially curative in early stage disease is a question that needs to be answered. The second line of research would be the determination of the cost effectiveness of these treatments in lower income countries, and whether these complex regimens can, in fact, follow the same paradigms that were used in HIV and hepatitis C treatment, where complex regimens can be delivered by non-specialist providers. In summary, our manuscript touches upon a very important aspect of treatment of hepatocellular carcinoma in lower income countries where the biggest burden of disease exists and where treatment options currently are highly limited. We talk about the role of immune checkpoint inhibitors and how these treatments can potentially be transformative for patients in prolonging life and quality of life, and potentially even being curative in its intent when other standards of curative intent therapy, such as transplantation, are not available. We encourage you to read our manuscript, and we hope you enjoy it.
We hope that you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel, www.youtube.com Mayo Proceedings, or journal updates on Facebook, www.facebook.com Mayo Clinic Proceedings. You can also follow us on X, formerly known as Twitter, available at Mayo Proceedings. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This content is copyrighted by Mayo Foundation for Medical Education and Research, published by Elsevier Incorporated. All rights are reserved, including those for text and data mining, AI training, and similar technologies.